Right. Welcome everybody to Cardiovascular Medicine Grand Rounds. Just going to take just 1 second here. Perfect. It is my great pleasure to introduce today's speaker and good friend, Dr. Michael Ghannam. I think that I can truly say that Dr. Ghannam is a longtime Michigander and Wolverine. He obtained his undergraduate degree and medical degree from University of Michigan. He also then completed an internal medicine residency and cardiovascular disease fellowship training at the University of Michigan, where he also served as a chief cardiology fellow. He then pursued further training in fellowship in electrophysiology at the University of Michigan, and we were very lucky to recruit him in 2019. His research interests are in cardiac imaging related to arrhythmias. In his relatively short career, he has published close to 100 articles in high-impact journals. He serves as a reviewer for many journals, including JACC, Clinical Electrophysiology, and he is the co-principal investigator for the International Database of Ventricular Tachycardia Ablations in patients with genetic cardiomyopathies. On a more personal note, I've known Mike since fellowship. We trained together since from 2014 to 2017, and we both started working on the same day in 2019. So we've shared many stories and many patients together. And, you know, I could use the next 60 minutes to talk about all the positive attributes that Mike has, but I'll just say that he's a true good friend, and he's that person who will always go that extra mile for every single patient and person he cares for. And I'm truly excited to learn from him as I've been doing all these years. So he's going to be talking about cardiac imaging of ventricular arrhythmias in and out of the EP lab. Welcome, Mike.
Oh, wow. Thank you so much, Victor. Appreciate it. It's an honor to speak here today, and thank you, Victor, for this opportunity. So today we're going to talk about cardiac imaging as it pertains to ventricular arrhythmias. And we're very fortunate in Michigan to not only have world leaders in electrophysiology, but also world leaders in cardiac imaging in our cardiovascular medicine and radiology departments. And together we've contributed a lot to this space. So I want to highlight some of the work we've done and give examples of how we use imaging in the EP lab. But first we're going to start out of the lab and discuss issues of risk assessment for ventricular arrhythmias, specifically shortcomings in how we assess risk and how imaging can help refine that risk. I think, yeah. So let's first examine the landscape of how ventricular arrhythmias and sudden cardiac death rates have changed over time. So this is a 2014 New England Journal paper, which started a lot of interesting conversations about sudden cardiac death, presumed arrhythmic in nature, in our highest risk patients, those with heart failure. So the investigators looked at trial data over time in patients with ejection fractions less than 40%, concluded that the rates of sudden cardiac death were improving, which they attributed to better medical therapy. Critics were quick to push back, saying that maybe this difference can just be explained by the severity of heart failure patients enrolled in these studies, and modern trials have been enrolling patients with less severe forms of heart failure. Additionally, even in the intervention arms of these modern trials, the residual risk of sudden cardiac death is still elevated at 3 to 4%. So I don't know what the acceptable risk threshold is, but for context, our hypertrophic guidelines would suggest if your annualized risk is greater than 1.2%, then you'd be appropriate for a ICD implant. So we currently rely on our assessment of ejection fraction for risk stratification. And these are two of the early primary prevention trials, now 20 years old, in patients with ischemic and non-ischemic cardiomyopathy, using ejection fraction cutoffs to decide whether or not a patient should receive a defibrillator. And we were able to demonstrate impressive reductions in sudden cardiac death rates, and the rate of appropriate ICD therapies in these early trials approached 50%. So it seemed, at least early on, that the EF-based approach was beneficial. If we fast forward a few years to the Danish trial, this is primary prevention ICDs in patients with non-ischemic cardiomyopathy and EF less than 35%, using modern therapy, including resynchronization devices, which we know lowers the risk of sudden cardiac death. And we see that this EF-based risk assessment still results in a reduction in sudden cardiac death rates, but overall the effect size is much smaller and manifests after a much longer period of time. And in fact, if we look at patients over the age of 70, there really doesn't seem to be much difference at all. So we're treating a lot of patients to help fewer and fewer people. So the other limitation with EF-based risk assessment is that we know most people who die in this country of sudden cardiac death will have a normal or only minimally reduced ejection fraction. And while the overall incidence is much lower, it's just a much broader group of patients that we're drawing from. So there's a couple a couple problems with this sort of simple paradigm. Is one, it's very difficult to adjudicate sudden cardiac death as arrhythmic versus non-arrhythmic out of the hospital. And also a lot of this may be due to unrecognized cardiovascular disease. But there are at least some registries with good follow-up and good echo data that support this, namely lower incidence of sudden cardiac death, but overall much higher numbers. And this is particularly true in these kind of medium or high risk subgroup of patients. So the question is, how can we better risk stratify these folks? And there's been a lot of proposed methods of risk stratification over the years. Things like T-wave alternans, heart rate variability, simple things like that do have some value, but late gadolinium enhanced cardiac MRI has really emerged as a powerful tool here. And it's our gold standard for detecting fibrosis and scar, which form the substrate for arrhythmias, usually in the form of these reentrant circuits. And we'll take a little closer look at that once we get into the EP lab. But it's been shown in multiple studies that the presence of scar is an extremely powerful predictor of arrhythmic events, independent of ejection fraction, across many groups, even those who would otherwise qualify for primary prevention ICDs. Unfortunately, this data has been difficult to translate into clinical trials. The Determined study had some promise, but was abandoned due to low enrollment. There's at least one ongoing trial, CMR Guide, which should come out next year, examining patients with moderate LV dysfunction and scar, looking at ICD versus loop implants. And this has the potential to change practice, so we'll have to see. Some barriers to implementing this, though, is that the LG-CMR is a resource-intensive test. It takes a lot of specialty expertise, and there's variabilities in how these studies are both acquired and interpreted. And we know that the composition of the scar matters too. This gray zone or border zone scar representing intermix of healthy and fibrotic areas of myocardium seem to be more arrhythmogenic than the dense scar tissue. It's how we adjudicate those with various techniques makes a big difference in what we report. We also know that certain phenotypes carry bigger risk, like this ring-like scar encompassing many segments here. And we put together our experience with Dr. Helms here, showing that patients with these ring-like scars often harbor inherited cardiomyopathies, such as Lammin and Titin and sodium channel-related cardiomyopathies, and those entail additional risk as well. So I'm hopeful that prospective studies will shed light on how to best utilize this technique, because there is a tremendous amount of promise here. But those challenges aside, there are some areas where the data behind LG-CMR is strong enough that it's made our way into clinical guidelines in everyday practice. And one of those is with cardiac sarcoidosis. And this is data from Dr. Crawford examining the risk of ventricular arrhythmias among patients with cardiac sarcoidosis and only moderate LV dysfunction. And he identified that the absence of scar is a very strong negative predictive value for arrhythmic deaths. He was also able to identify particular scar characteristics, including the burden, the morphology, and the distribution that signify particularly high risk. So if we look at the modern guidelines for sudden cardiac death prevention, we see that ICDs are reasonable among just this population, mildly preserved EF, but the presence of cardiac scar. The second area is hypertrophic cardiomyopathy, and both the European and US guidelines support incorporating LG-CMR scar assessments along with other forms of risk assessment into decisions on ICD implantations. And again, the amount of scar is key. It seems to correlate with arrhythmic events. And that's important to note because it's, we do see scar in the majority of patients with hypertrophic cardiomyopathy, and it's not clear that an ICD is indicated in all these patients. So wrap up this section, I want to talk about how we will use CMR for risk stratification today. So here's a typical patient we'll see in the EP clinic. It's a 67-year-old woman referred for evaluation of asymptomatic PVCs that were detected on a routine EKG. A Holter monitor showed about a 5% burden. Ultrasound would show normal ejection fraction. She had a negative ischemic evaluation. She had a cardiac MRI that demonstrated this inferior lateral scar. You can see this here. She even went as far as to have a nuclear FDG scan showing no inflammation. And the thought was, well, this scar may be healed myocarditis, early non-ischemic cardiomyopathy. And the question is now, what do you do with a patient like this? She's feeling fine. She's a little annoyed at all these expensive tests and is wondering why she was referred here in the first place. So because it's been our practice to do routine MRIs on these patients, we're able to put together a large series of 272 such patients with kind of low-risk PVCs and what we called apparently normal hearts. That's normal ejection fraction, no obvious structural heart disease, no ischemic heart disease on ultrasound. We find that in a surprisingly high number of patients, 25% will actually demonstrate cardiac scar. And again, these are relatively healthy young patients with preserved ejection fractions. We're also able to see that by looking at the amount of scar, we could pretty accurately predict whether or not these patients would be inducible for ventricular tachycardia in the EP lab. Again, going along with prior reports showing that the scar burden is very important. And in addition to the unexpected high prevalence of scar and the importance in the lab, we saw that this translated into real-world event rates among these patients. So because of this experience, we've continued to use CMR and EP studies widely in this population in patients who we traditionally may have dismissed as low risk. So one of our medical students, Trisha Gupta, now doing a Sarnoff fellowship, looked at this too. She examined patients with symptomatic arrhythmias, mostly NSVT, without ICD indications. And these patients even went as far as to have negative EP studies and had loop recorders placed to really track their arrhythmia burden. And even with the assurance of a negative EP study, we found that the presence of scar had a very high impact on the rate of ventricular arrhythmias independent of a lot of features, including ejection fraction. So patients with scar and ventricular arrhythmias really need to be followed very, very closely here. So we go back to our patient, we take her to the EP lab. And in the setting of her scar, we perform programmed ventricular stimulation for risk stratification. And this is a technique where we pace the ventricle at predetermined intervals and try to induce these sustained arrhythmias. And in her case, we were able to do that and implanted a cardiac defibrillator. And similar to our study findings, the patient will go on to have VT and appropriate ICD therapy over time. So, despite advances in medical therapy, sudden cardiac death and ventricular arrhythmia remains a real issue for patients, both with overt and only minimal forms of heart disease. And while ejection fraction is a powerful measure of arrhythmic risk, it's not perfect, particularly in modern cohorts. And LG-CMR is a powerful tool for assessing risk, but it's very resource intensive and lacks prospective data on how to implement it. So what I want to do now, we'll change gears a bit and talk about our experience here at the university using cardiac imaging in the EP lab and how we use it to target arrhythmias. And we'll focus mostly on ventricular tachycardia, although we do have important uses for it for focal arrhythmias such as PVCs. So the key feature of how we use imaging is really to identify the arrhythmogenic substrate that we need to target. And so by way of an introduction, I want to talk a little bit about the original procedural approach for substrate modification. And this began in the 1950s with these left ventricular aneurysm resections. This was in patients with myocardial infarctions, I should say. So this was initially done as a primary treatment to relieve heart failure symptoms in these patients, but surgeons learned that their patients also had less VT often. And through the 70s, this was the recommended treatment for refractory VT, revascularization and aneurysm resection. However, as it was expanded and studied upon, it was clear that just removing the aneurysm alone was really insufficient, and a lot of patients continue to go on and have arrhythmias. So Dr. Josephson is a founding figure in EP, used intraoperative mapping techniques to help figure out why this technique failed. And he, along with his surgical colleagues, performed intraoperative mapping to demonstrate that the earliest regions of activation during VT, or the sites we think are most critical, don't occur on the epicardial border or even in the aneurysm themselves, but really in the endocardium surrounding the infarct zone. Again, at this intermixing of healthy and scarred tissue. And that's in line with our understanding of ischemic processes as a endocardial to epicardial phenomenon with the kind of preserved tissue around the infarct zone. So they performed a technique called the Pennsylvania peel, where they would not only resect the aneurysm, but they would take out several centimeters of healthy endocardium, extending around the infarct zone, and this was an effective solution. So if we fast forward a few years, in 83, we see the first reported cases of catheter-based VT ablation. And these were initially done using very high voltage direct current shocks that would suddenly cause a lot of damage to the tissue. And then in the 90s, that would give way to the alternating current radio frequency energy we use that slowly cooks the tissue, basically. And as we became more precise with ablation, we had to better understand these circuits to maximize our efficiency. And this is one of many landmark studies by Dr. Murati, showing that by using pacing techniques during VT, we could really understand these arrhythmias. And we began to learn that, these arrhythmias basically are composed of these areas of fixed conduction and slow conduction that cause these reentry circuits. And if we fast forward a few more decades to the 2000s and 2010s, we enter the era of electroanatomic mapping. We have these systems that can generate 3D structures of the cardiac chambers and accompanying electrical activation. And this map, for example, has over 5,000 highly automated points that's collected in just about 10 minutes, showing this circuit. So what we are looking at is electrical activation over the ventricle. You see this reentry circuit we described earlier, this slowed area of conduction here and rapid conduction elsewhere. And if we target this area of the myocardium, we can effectively terminate this arrhythmia. So by studying and ablating during VT, we can learn a lot about these circuits and where to ablate them. But ablating during VT is difficult. Not unexpectedly, most of the VT we see in the lab is not hemodynamically stable enough for us to spend 10, 20 minutes mapping. And we can make it more stable by infusing high doses of pressors or using mechanical assist devices, but even that has issues. So, for example, in this study, investigators placed impellers during VT ablation, not to support sick patients, which we sometimes do, but primarily to facilitate mapping. And with this level of support, mapping certainly is easier. But they found that even with the impella and all the complications it brings, patients still can experience hypotension, or in this case, they looked at cerebral hypoperfusion during VT. So in light of these challenges, substrate-based ablations were introduced around the year 2000. And there's many ways to do this, but the heart of the question is, should we only target the clinical VT, or should we target the substrate as a whole, and eliminate not only clinical VTs, but potential future arrhythmias? So the panel below shows this kind of a more focused approach. So this is our electroanatomic map, and these areas in red represent electrically defined scar. And what the investigators did in this focus technique is they used some of those focused studying of the circuits during VT to understand the most critical components, and did this kind of more limited ablation. And in this panel, you see a more global substrate approach where everything that's red is being targeted with ablation lesions, these little red tags here. And these studies and others show that this substrate-based ablation can lead to better outcomes. So that's all well and good, but the problem is we often see patients with very advanced heart failure and ventricular arrhythmias who require ablations. So this is a patient with a 9-centimeter ventricle, very advanced ischemic heart disease, who was undergoing ablation. And the heart's very remodeled and kind of like a globe, basically. So we're talking about something just under the size of a softball, and our catheter tip's only about 3 millimeters. You can see it kind of swimming around in there. So if we just define the substrate electrically, we're talking about an enormous area, and there may be some areas that are more critical than others. The other problem we see with just relying on electrical information is shown here in this patient with non-ischemic cardiomyopathy, and this very deep-seated intramural scar you see here. Because our catheter tips really only sample the very immediate vicinity of their electrodes, this rim of preserved tissue here can actually register as normal tissue, shown here by these very sharp high voltage electrograms here. We have techniques to broaden our antenna a bit, but it's very easy to underappreciate the substrate if we just rely on electrical information. So the goal of using pre-procedure imaging is to provide a roadmap of patients' substrate that can assist us in risk assessment, patient consultation, help us plan for special techniques for intramural and epicardial scar. But the real big question is, are we actually improving outcomes? So these imaging tests incur additional costs and inconvenience. They carry small risks, and the question is, can we justify this practice? So the first attempts at integrating imaging into the EP lab were performed in patients with ischemic cardiomyopathy, and the first study was actually done with nuclear perfusion imaging. And this 2008 paper shows how you can take the information from perfusion scans and recreate these very nice three-dimensional representations and overlay them into that electrical data I showed you. You can see that this large area of a perfusion defect roughly correlates with this electrically defined area here as well. And then later that year, this same technique was demonstrated with cardiac MRI. And this is when we really began to learn about the limitations of our electrical activity. So in this initial study, a full third of cases had major mismatches between electrically defined area and the infarct area defined by cardiac MRI. But things got really interesting the same year, 2008, when with this landmark paper by Dr. Bogan and Dr. Murati showing for the first time you can use this technique in patients with non-ischemic cardiomyopathy. And until then, a lot of our knowledge of VT circuits really came from ischemic patients and ischemic animal models, which is, again, largely an endocardial process. And this is the first paper to show that we can extend these findings to patients with intramural scar and epicardial scar. And they were able to show that indeed patients with, by using LGE-defined scar as the gold standard, they were able to show indeed that patients with endocardial scar had endocardial arrhythmias and patients with epicardial scar had epicardial arrhythmias. And this intramural scar is both difficult to identify and target. And these are things we kind of take for granted in the lab now, but this paper was very important in kind of advancing our understanding of that process. So by using information from the catheter ablation, histology, and now imaging, we begin to better understand these VT circuits, namely that these circuits don't just involve dense scar, but these border zone areas of mixed healthy and unhealthy scar, which we can see on CMR. We also learned that myocardial calcifications can form some of these fixed borders that we talked about. This is a paper from Dr. Aliyesh, one of our former fellows here too. And then we also learned that these circuits aren't necessarily confined just to the endocardium or just the epicardium, but can involve multiple layers or even be contained within the intramural layers themselves. So using imaging to identify this scar is critical to a successful procedure. So based on our experience and along with the expertise of our colleagues in the Department of Radiology, we've been routinely incorporating imaging into VT ablation, particularly in the case of non-ischemic cardiomyopathy, where again, an understanding of the scar location is so key. Several years ago, we put together this series showing that by using pre-procedure imaging, we can improve not only the acute success in the lab, meaning rendering patients non-inducible for VT, but this also translates to better long-term outcomes. So how do we actually use these techniques? We published on the specifics of our approach a few years ago. That is kind of a stepwise approach. First, we'll utilize sort of the more traditional mapping and ablation techniques that we talked about, but if those techniques fail, then we'll ablate tissue directly guided by our overlaid images of the LGE CMR that we incorporate into our mapping systems. And this is a bit of a departure from prior techniques, but we were able to show that it has some value. We're also able to examine the importance of scar depth on our ablation outcomes. And we looked at what percentage of scar is deeper than 5 millimeters from the endocardial border. And this is roughly the amount of depth we can get with our catheter ablation. And we found that success was related, again, in large part to the amount of scar, but most importantly, the depth of scar. And patients who had more than 20% of their scar at regions greater than 5 millimeters had the worst outcomes. And we're also able to show that this approach improves ablation outcomes compared to those undergoing a traditional non-image guided approach. So while CMR is the gold standard for scar detection, we also found really good uses for cardiac CT, particularly in patients with ischemic cardiomyopathy. And the advantage of CT is that it has a much higher resolution. It's really well equipped to examine features like wall thinning and myocardial calcifications, which are not well seen with cardiac MR. And we find the best outcomes occur when we combine these approaches. So we'll go over a typical case and demonstrate our workflow. So this is a patient, is a 55-year-old man, longstanding history of ischemic cardiomyopathy. He had his first MI 10 years ago, has had multiple revascularizations and has since developed drug-resistant VT and ICD shocks. His EF's 20%, very severe LV dilation. You can see this anterior apical and septal akinesis and wall thinning. So pre-procedurally, we obtain a CT and a cardiac MRI. Excuse me. So the CMR is shown on the left, and it's showing various components of endocardial and intramural scar, and then the CT here is demonstrating that septal and apical wall thinning here that we saw on the echocardiogram. Now, if we zoom in on the segment of septal myocardium, we see that while the echo suggests kind of a thin, homogeneously scarred heart, the CT shows it's really a much more complex process. And we see that this area actually has a very complex topography and different areas of wall thinning and thickness, as well as this bright area of myocardial calcification shown there. Now, we're only talking about a few millimeters difference, but it actually translates into some very important findings in the lab. So we can take these images and we export them to a company called InHeart, which was started with investigators at the University of Bordeaux. And our division has had a lot of great collaboration with the team over the years. And what they do is they take all the data we send them, and they're able to recreate these very detailed maps of the wall thinning, represented by this color scale, again, showing this pretty complex topography. And beyond that, you can see how much anatomical data we get on the atrium, the aorta, the coronary arteries, the coronary venous system, and even the patient's ICD lead is rendered in very nice three-dimensional detail. So we get a lot of information here. And then we can combine this cardiac CT and cardiac MRI images into one comprehensive map, and that's shown here. And we see that within this dense area of anterior and septal scarring, there's this channel of preserved wall thickness, 5 millimeters here, 3 millimeters here, surrounded by 1 millimeter borders here. So keep in mind that kind of walls and hallway kind of reentry circuit we saw earlier. We also see that if we overlay with the MRI, that correlates very nicely with this border zone scar, which we said is where these arrhythmias tend to reside. So our suspicion going into the procedure is that this may be a critical isthmus, or at the very least an area that we want to focus on. So how do we actually integrate these images? Well, we utilize another important technique, intracardiac ultrasound. So here we have our ICE catheter positioned within the right ventricle. And by sweeping around and outlining the endocardial borders, we can get this very nice high fidelity map of all the anatomy we need in just a few minutes. The next step is integrating these images into our anatomic map, and to do so, we typically select fiducial points on our CT images as well as our ICE-derived images, the apex, the annulus, and the aorta here. And you can see we get this very nice overlay, and it meshes very nicely, and the mapping system can give us feedback, and we can usually get a mesh with only a few millimeters of error. So during the procedure, we have our electrical data again. This is the area in red representing areas of scar within the region. And you see where our catheter is, it's very low voltage and fractionated signals. And we use this technique called pace mapping. By stimulating the myocardium at that site, we can very nicely recreate the patient's clinical arrhythmias, suggesting that this is in fact an area that's activated during VT. And again, you can see that lines up very nicely with our CT findings as well. So we put together our experience of using this technique, using CT images to define these areas of wall thickness as a way to identify sites critical for VT. And we found that the topology of patients with chronic ischemic cardiomyopathy can get very complex. However, in the majority of patients, we can identify VT target sites contained not only within areas of wall thinning here, but between areas of wall thinning and anatomic obstacles like the aortic valve in this patient here. So even if we don't want to fully commit to this integrated 3D reconstruction, the use of imaging is still very important for procedural planning, particularly for patients with non-ischemic cardiomyopathy. We learned from our previous study that deep-seated scar is more challenging. And here we see a patient with non-ischemic cardiomyopathy and preserved and really hypertrophied septum here, 20 millimeters thick. with scar that extends as deep as 7.5 millimeters from the endocardial borders. And this can be really challenging to reach from endocardial ablation alone. So here's a demonstration of some of these limitations. We, again, using intracardiac ultrasound, we're looking at the real-time lesion formation during an RF ablation. And you can see the edema created by our RF lesion creates this very bright enhancing region on ice. You can see even after, you see the lesion grow over time, but even after 2 minutes, there's a limit to how deep we can get this RF energy to penetrate. So this is just another zoomed in image there showing that along the endocardial border, we have our nice bright lesion, the epicardial border here, but this area of unablated tissue that is difficult to target despite our very aggressive ablation. The problem with being too aggressive is that we can see this phenomenon called a steam pop, where the water content in the cells is heated so rapidly it basically explodes and in a cloud of steam. And Dr. Liang put together these very nice images of kind of the after effects of some of these steam pops, and you can see just absolute cratering in some of these hearts. And we were able to work with Dr. Gordon in the Department of Pathology and look at the MR and histologic findings of these patients. So this is a patient with a lamin mutation going to an aggressive ablation, experienced a steam pop, and later went on to have a cardiac transplant. The histology here shows this intramyocardial hematoma and necrosis even weeks later. So in these difficult cases, we can try techniques such as bipolar ablation. So typically we ablate with a single RF catheter, and the circuit is completed by a remote grounding patch, meaning that while we heat the tissue, we do lose a lot of current to the surrounding blood pool. And in bipolar ablation, we actually position 2 catheters opposed to one another. You can see here's one coming up through the aorta and retrograde through the aorta rather, and one in the right ventricle opposing each other. And by focusing our current, we can actually improve the depth of our lesion formation. So this is a before and after patient image of a patient who underwent bipolar ablation. And you can see that by using this technique, we really are able to get into this deep intramural scar. So we'll look a little closer at these, you can tell that the post-ablation lesions have distinct MRI findings, and we are going to look at that too and see how we can use that in the lab. But the other way we can use CMR is to help plan and execute epicardial ablation. So this is a 55-year-old man with non-ischemic cardiomyopathy, extensive history of VT, including a failed endocardial ablation. You can see the reason why an endocardial approach was perhaps unsuccessful. His scar is located here around the epicardial border, and you can see some endocardial lesions, but really that epicardial scar remains untouched. So we can send these imagings off, we can obtain a CMR and a CT, send them off for processing, and we get this very nice reconstruction demonstrating not only the epicardial scar, but the surrounding vasculature as well. And you can see from this intra-procedural angiogram how nice these coronary arteries actually lay out, and unfortunately right over our area of interest, over his epicardial scar. But despite the proximity of this, the epicardial procedure was deemed necessary. And here's images from our epicardial axis. So we have a guide wire in the pericardial space here. We've positioned our sheath and we're injecting contrast to confirm position. And then we have our ablation catheter positioned within the pericardial space here. And this is our final lesion set in the patient. Again, the red tags represent areas of ablation. And by using the image overlays, we are able to cover as much of the scar as we can and avoid directly ablating over these critical structures we can damage with RF, like the phrenic nerve and the coronary arteries. So we can do this short of imaging, but it's very tedious, requires a lot of contrast injection, radiation, and time. So these imaging overlays help improve the efficiency of our procedure quite a bit. And you can see on the follow-up MR, we've now obtained this nice coverage of a scar along the epicardial border here. The other kind of window to the epicardial space, short of a subxiphoid puncture, is the coronary venous system, both through the great cardiac vein, the anterior intraventricular vein, and on angiography here, you can see these large lateral vessels can often accommodate our ablation catheters. So this is a particularly useful technique in patients with non-ischemic cardiomyopathy. You often have a lot of basal substrate, but also have layers of epicardial fat along those basal layers, which can basically insulate against direct ablation from the epicardial space. So it would be nice to know beforehand, is this an option for patients? So here's one such patient. This is a gentleman with a JUP mutation. You can see just extensive cardiac scar throughout the septum, endocardial scar. But here on the very basal segments, on these red arrows, you see that there is some epicardial scar. And the question is, well, is an epicardial approach going to be necessary, or is it something we can access through the coronary venous systems? And, excuse me. Yeah, so we wrote up our experience using this technique as well. Again, using our collaboration with InHeart, they were able to create these custom heat maps for us. So we can get, such fine detail with these meshed maps that we can tell how far is the coronary venous system from a patient's epicardial scar. And we're able to show that we're able to predict with pretty reasonable accuracy whether or not going within the coronary venous system is going to be a useful endeavor. So here's one such patient. This is sort of a left anterior oblique position. Our ablation catheters within the coronary sinus. You can see by using that pacing technique we described earlier, we get this very nice match to their clinical VT and had a successful procedure short of an epicardial puncture. So just another interesting way we can use these images to help plan out these ablations. So we've seen in several cases that ablation lesions can be visualized on post-procedure CMR, and that raises a lot of interesting questions, including what's the nature and significance of these findings? And, from our world, can I exploit this to help my patient? The first investigations into this were in animal models in the 2000s, where investigators would create these lesions in I believe, dogs, and would just image them serially. And they show that this lesion formation is a pretty dynamic process. Immediately after ablation, we get this contrast void, a complete lack of uptake into this region. And that slowly starts to recede, and then we see peripheral enhancement into the lesion. And then as the acute edema starts to recede, we are left with this final enhancing lesion shown here. And they were able to show that this correlates pretty well with pathology, showing new fibrosis related to the ablation lesions. But what about in humans? So Dr. Bogan published this series in 2010 among patients with idiopathic arrhythmias, and reported similar findings. Basically, on chronic imaging follow-up, patients without underlying heart disease demonstrated this persistent enhancement consistent with new fibrosis. And the degree of enhancement correlated pretty well with the amount of RF energy that we delivered to the tissue. But interestingly, the picture is much different if we look at patients with existing scar already who undergo ablation procedures. So these patients already have areas of white hyperenhancement, and rather than seeing kind of a white lesion on white lesion pattern, we actually see kind of a black on white formation where these patients will have persistent areas of no uptake, or this microvascular obstruction phenomenon that persists for many, many months afterwards. You can sort of see these before and after pictures here. So you have the patient's native scar and these, we began calling them dark core lesions, just given their appearance overlying their native scar. And we were able to show in the same paper that we can identify these regions and export them along with any other information as we would on our CMR reconstructions, and incorporate them into follow-up ablation procedures. And we were able to show that these dark core scar areas represent electrically inert areas of the heart. And so why we see this dark scar is not really clear, I don't think, if it's true microvascular obstruction related to the ablation lesions, or would they eventually uptake contrast if we extended out our imaging window, and whether that would be from direct perfusion or just diffusion into the tissue. It's not really clear, but at least, we found that, again, from the clinical point of view, it is a very useful finding that we can exploit. So the next step, after we were able to show that the electrical properties of this dark core scar, we wanted to further see how it related to VT circuits. And we did that in a follow-up paper showing that indeed these prior ablation lesions can form those fixed barriers that we saw earlier, and that these are often related to new VTs in patients who have recurrent VT after failed ablation procedures. In the same paper, we're able to show that by incorporating these dark core images into the follow-up procedures, we could improve our procedural outcomes. And these were actually done in patients who were arguably sicker with higher rates of VT storm. But nevertheless, using our imaging, we could have better ablation outcomes in this very challenging population. So the next step was to look at non-ischemic cardiomyopathy, and this is where it becomes really complicated. And within the same patient, we can see both areas of dark core scar as well as areas of enhancement. And so these images are in the same patient post-ablation, just looking at different slices. On the left, we see this relatively thin area with native scar and the dark core scar lesions shown here. And more apically, there's more preserved thickness of heart tissue, not overlying scar, and we see this uptake. So the nature of these lesions depends not only on the imaging modalities, but the underlying scar tissue being ablated. And again, working with Dr. Gordon, we were able to describe the gross anatomy and histology of these scars. So this is a patient with non-ischemic cardiomyopathy who underwent an extensive ablation. And you can see it here. Again, these red tags are ablation lesions in the basal septum over the LV and the RV, trying to target this deep intramural scar. And on gross pathology, you see this kind of white lesions, white areas consistent with this the fibrotic areas of the heart. And in the patient's histology, we see that these dark core lesions correlate with areas of coagulative necrosis overlying this intramural scar. So what we learned from this series of papers is that we can see alternating enhancement or dark core scar depending on the underlying substrate. And I think the mechanism is still possibly up for debate, but and again, depends apart on our own imaging protocols. But from the clinician's point of view, these dark core areas do provide useful information. So I'll show one more patient that highlights this and hopefully pulls together a lot of what we've covered here today. So this is a patient, he's a 65-year-old man with a right coronary artery infarct and ischemic cardiomyopathy who underwent a failed ablation at an outside hospital 10 months earlier. And the referring physician felt that the reason for the failed procedure was an inability to eliminate the clinical arrhythmias, which they felt were originating on the epicardial surface. And that's quite plausible. We know that, we mentioned ischemic cardiomyopathy is an endocardial phenomenon, but we do know about 15% of patients with ischemic VT will have epicardial circuits. However, our imaging shows that, the scar is very well defined. It's very thin, only 1 to 2 millimeters thick in most regions. And that's usually something we can target with our ablation. So we, keep an open mind and we obtain our pre-ablation imaging. Again, we obtain our CMR and our CAT scan, overlay the images, and we can see both the patient's native cardiac scar and then this the results of the prior ablation lesions superimposed here. So this is a posterior and caudal view during the procedure. And this red area here, again, is our electrically defined scar, as we expected, this inferior and septal scar. And here we've overlaid the patient's dark core imaging. And you can see that there is this large contiguous area of dark core scar of electrically inert tissue, but here along the borders, it's much less less homogenized, and we see these, again, corridors of possible conduction. And indeed, that's what contributed to the perhaps failure of the last procedure. We were able to find VT target sites by focusing on these areas of less intense dark core imaging. And there's one more interesting aspect to this case, which contributed to the failure of the prior ablation. And here on real-time ICE imaging, we see this echo-dense structure here, very much distinct from the papillary muscle running this way. And we can trace it out here. It's a subtle finding, and our catheter will often slip right off of this while roaming around the ventricle, but ICE can be very key in identifying these intracardiac structures. So here's another quick example of how we'll use ICE. This is ablation on a papillary muscle. You can imagine this is a very small, very mobile structure within the heart. We're trying to balance our catheter on it while the heart's beating, and it's can be a very challenging thing, but with ice, we can visualize not only good contact, but lesion formation as well. We see again this large ball of edema from a successful ablation on this papillary muscle. So one of our former fellows, Dr. Hunterkal, put together this series with Dr. Bogan showing the importance of these very subtle structures. And with multimodality imaging, we can see that these papillary muscles are really pretty complex structures. They often have multiple heads and various connections to the myocardium themselves or other parts of the heart. So among 153 papillary muscle-related arrhythmias, we were able to show that indeed most of these arrhythmias can be mapped to what you might call the papillary muscle body proper. However, there are a lot of other structures that are key here. So we see these accessory papillary muscles, like our patient we're just talking about now. There's papillary muscle to myocardial connections from the main body to the wall of the ventricle here. There are papillary to papillary bridges. There are connections from the papillary muscle to the mitral annulus. And all of these different origins have distinct EKG features depending on where the signal is exiting these structures, where they're connecting to the rest of the heart. And this has not been previously described, but it's very important to recognize as they can harbor these arrhythmias. So we go back to our patient, again, using our multimodality imaging approach. We're able to identify that he indeed did have an accessory papillary muscle shown here, and again here in green. And by positioning our catheter carefully on it, we could find additional clinically relevant arrhythmias that ultimately contributed to a successful procedure. So to wrap up, what I hope I showed is how multimodality imaging can provide a very comprehensive assessment of the arrhythmia substrate, both from a gross perspective, but also on very fine levels of detail, and how this can be used to plan accordingly for challenging cases and help advise patients on procedural risks and the expected outcomes of the ablation. And I do believe these techniques can simplify these complex procedures and improve patient outcomes. There's some really exciting frontiers opening up in this space. Again, the type of data we get from imaging and EKGs and intracardiac electrograms seem well suited to applications in artificial intelligence and machine learning. And we've already seen some really interesting papers, not only on risk assessment, but also scar analysis, image analysis, and identifying critical ablation sites. And my hope is in the future, we move towards a more image-directed ablation, meaning entirely in the pre-procedure setting, we can create a total plan of attack and know precisely where and how to ablate these patients, and hopefully make these complex and risky procedures a lot more predictable and safer. And these gains, of course, will be made in parallel as we improve our imaging techniques and our understanding of arrhythmia circuits. So I just want to acknowledge the great team we have here, both within EP and radiology department, and particularly Dr. Bogan, who is a pioneer in the field as well as a good friend and mentor. So I appreciate all the support over the years. So I thank you all for your attention today.
Right, great, Mike. That was a phenomenal presentation. I'm going to start off with one question. We have about 10 minutes, so there will be plenty of time. You've talked a lot about all the advancements on catheter ablations. You talked about all the imaging and interlane. Sitting from a clinician's perspective, what can we do medically, to maybe prevent ventricular events in patients who have known arrhythmias? Is there medical therapy that can help with that, or once you see a patient with a ventricular tachycardia, you're thinking that this is going to be something that primarily needs to be treated with a physical catheter ablation in a way?
Yeah. Well, I will say, we talked a little bit about whether or not we are actually making headway in reducing sudden cardiac death. There is data from the newer trials that they do, like if you look at the subgroup of the modern trials, they like the SGLT2 inhibitors, and those do seem to improve sudden cardiac death rates. So from a medical perspective, of course, I don't need to tell you all, but guideline-directed medical therapy does seem to help. The other thing, I think the trend in VT over the years has been a better understanding that getting to these patients sooner rather than later is going to help improve their outcomes. This used to be reserved as like a salvage therapy, and we'd only see very, very sick patients. But getting, identifying patients who are having arrhythmias, getting to the lab sooner is probably going to improve their overall prognosis.
Any questions with it, Dr. Minsky?
I can't let this go by without saying, wow, that was a tour de force. I mean, absolutely. And for people who are trainees or maybe junior faculty, just watching the dates on your publications, 2017, 2018, just prolific, fabulous. So then a scientific question, Mike, is you have all these different imaging modalities. You talked about AI. How do you fuse them all together so you can have this really easy, comprehensive preoperative plan of attack? Do you do 3D printing so that you can actually know where you want your catheter to target? Or how do you fuse it all?
Yeah, the big thing is, they broadly call it in silico mapping, where they look at, again, as much data as you can give them, MRIs and fiber orientation from CTs and TEEs and the clinical electrograms of the VTs. And the idea is to create a kind of an atlas of the heart and say, we think this area of the heart is responsible for this arrhythmia and this specific thing. So the printing I'm not sure about, but that's sort of this in silico arrhythmia mapping is where I think this is all headed.
Mike, I have another question. It caught my attention a lot what you kind of mentioned at the end that, you're seeing the future of ventricular arrhythmia ablation being directed to having more imaging, knowing the patient more, and hopefully, planning for, less adverse events. Is there any data on this approach, having less adverse event because you know the patient better, because you've planned the procedure? Or if not, that may be, an interesting thing to explore.
Yeah, it certainly would. I mean, I think, we've certainly showed, you mean from the acute procedural safety perspective? Yeah, it's hard. Well, we certainly can show things like faster ablations, which translate to less fluid, which translate to less hemodynamic, insult to patients. So I think there is good reason to think that would make it a safer procedure. The serious complication rates are low, to begin with. So it's hard to show a good distinction without many patients. But I think these kind of surrogates of safety, and certainly our experience would suggest that it is acutely more safe. Yeah.
Also, the success rate is also higher. Success rate is also higher when we have more imaging, as Mike demonstrated in the slides. We compare the patient population, historic patient population where we had no MR imaging, to a patient population and consecutive patients with non-ischemic cardiomyopathy where we had MRIs, and the success rate was higher and the recurrences were lower of the arrhythmia. So knowing more is definitely better. Less information.
Great. Any, Dr. Orell?
Mike, thank you so much. So fantastic. Ventricular arrhythmias all around. So, two questions. One is that, as you know, several years ago, there was a lot of hype around real-time MR-guided imaging and ablation. Where do you see the status is? I know that those devices exist in select. Do you think they will be able to one day before I retire do real-time MR-guided ablation in the ventricle?
Yeah, I think, correct me if I'm wrong, I think that only centers in Europe are doing it currently, if I'm not mistaken. It requires a lot of specialty equipment. It's a whole lab overhaul to have a MRI compatible ablation and monitoring and anesthesia. So I think any potential promise, and there was some, I think it was kind of squashed by the extreme technical difficulties in executing it. I don't think we have any institutional experience here. And yeah.
Can I make just a comment on that? We've actually been on this journey here. When we built the cardiovascular center, we weight bared the floor. We spent a lot of money. We weight bared the floor so we could put in an MR We put in MR, Ghannam will remember this, as will Frank and people who've been here. We put in a real-time MR, and so we had it. We spent a fortune, and it went largely unused. I think maybe one of the faculty liked it. And you can tell me the experience, but my understanding was it just wasn't as easy. The catheters were sort of floppy, and then they would stiffen in the field, and they would, but apparently it just took like twice as long to do a procedure. And maybe somebody can comment. So then we spent more money and we removed it from here to put in a regular non-mapping thing. So we did have that experience. I don't know if somebody wants to comment.
So the system, the MR system, that was in essence magnetic guided navigation. It was a large magnetic field of earth magnets around the patient. So that, we could still control them without that on our back and with a joystick, we would move like catheters inside the body. We call the straight axis system. But it was kind of inefficient, and the hope was eventually the system would evolve into something like a real-time MR. And so, as you pointed out, it was very inefficient. Only one of us liked it, and none of us likes doing 12-hour cases for otherwise 2-hour case. So just it took us a lot of effort to put on eBay. Really put that on. But eventually we converted that to EP5, which is a state of the art. And the next phase was bringing a real-time MR system here as one of the investigation sites. Pediatrics needing the effort because it's time radiation, not fluoroscopy. So they couldn't move that forward. It was quite an expensive investment, and the signal quality signal noise ratio in the magnetic environment is less than accurate. So we prefer to have a system where we see what we update defined by the electrogram versus an MR image. So this way we left it. And there are a few centers, one in Germany, one at Hopkins, who have real-time MR in the open, but there has not been a need over the last 5 years or so. So we'll see what time tells us. And just there's one other system, hopefully. Let's see.
Very good.
I have one last question here from Amang Chug. Says, tremendous talk. Thank you for an amazing presentation. Any updates on the needle electrode ablation for deep substrates?
Yeah. Well, it's still under, yeah, so the idea there is we pointed out several times how, even under the best of circumstances, it's hard to get the endocardial heat to penetrate deep into these very tough substrates. So investigators at, I believe it's Dr. Stevenson, I think it's back in Boston now, I think, developed this needle approach where you can pose the catheter to the tissue, insert a needle deep in the tissue, and kind of begin the heating process in more. They reported very good results. I think it's still under investigational use. It's sort of like bipolar. I didn't really explain it here, but it is a tedious thing. You can't do this technique along these extreme substrates, but for very focused ablation in critical areas, it has a lot of promise. And they've published a lot of data on it. It's not available to us just yet.
There's one more question, Dr. Cyberlick.
Go ahead.
This is less of a question, more of a comment. So speaking from the MRI technology development perspective, we would be quite eager to talk with you about real-time imaging and different kinds of, properties that one can look at. But there are, like when it comes to, thinking about real-time imaging for ablation, like in gantry ablations, we have a new MRI system that's lower field, but has a large bore. And there's a lot of interest within radiology about doing interventions in that system. So I think it's been around for a long time, and maybe it's always going to be the technique of the future, but I think that it would be really cool to see if there's interest, where that could go.
Thank you very much. All right. Thank you, Mike. Thank you so much
Victor.
for this presentation.
Appreciate it. Thanks, Victor.